still hear me?
Yeah.
Oh, perfect.
Thank you.
And so now, she looks straight into the camera. What I'm going to do is, I'm going to talk about her geometric landmarks. So, the width of the female chin, it should be the same width as her nose, which should be the same width as her intercanthal distance. Just take a look at her. The nose is wide, the chin is wide. Do you agree?
Yeah.
So how do we deal with this? We inject into the piriform and into the apex of the chin to give a balance. The intercanthal distance is the reference point for the measurement of the vertical fifths. It doesn't change throughout your life. And now we look at the width of the eye. The width of the eye should be the same as the intercanthal distance. Do you see that on her lateral canthus there's a slight downward tilt? Okay, it makes her eyes look sad, not just her mouth. That's why you think that she's looking sad. So we need to elevate the lateral corner, and that's going to be through temple, zygoma, lateral lid cheek junction. And then in the lateral fifth of the face, it should be the same width as the intercanthal distance. And she is narrow in the temple, isn't she? You see that? But the zygomatic projection is adequate. So what I'm going to do there is, I'm going to treat in keeping with the geometry. Look at the horizontal thirds. So that from the hairline and to the glabella, to the nasophiltrum, and then to the mentum, those 3/3 should be equal in length. It's pretty good, right? It's pretty good. So, although she wants to have chin narrowing, okay, in support of the mandible, it's important that I don't elongate the chin, because what's going to happen? I'm going to move this relationship here from 1/3 to 2/3 into 1/4 to 3/4, which is masculine. Okay, cool. So let's mark up.
It's nice and to see the difference between this patient and the previous one.
Yeah.
With a very narrow and a very pointed chin, and this one here with a very wide chin.
So just to summarize again, if we want to make the chin narrower, we're going to inject here at the apex. If we want to make the nose narrower, we inject here at the piriform. If we want to make the eye wider, we're going to inject into, see, look at the relationship between temple and the lateral canthus here. So we inject into temple, zygomatic arch, and then at the eminence, which should correspond to just medial to that zygomatic retaining ligament. And then in the lateral fifth of the face, she's adequately projected, and poorly projected. So this is going to be the priority here. And then when we come into this local region and we look at the geometry, this should be 1/3 to 2/3, which is pretty good at the moment. And we should see within the body of the lip, 1/3 to 2/3. She's more dominant in the lower lip, so there is a role here for upper lip eversion. Let's look at the profile now. So come this way, all the way around. Good. You can see really clearly that when I evaluate her rickets line like this, that the pencil is touching the lower lip. It should be 2 millimeters away. And the upper lip, it should be 4 millimeters away. It's actually a little bit more than 4. So, when I do this with the chin, look, I push it forwards. I clear 2 millimeters from the lower lip, and then the upper lip is going to come forward to meet the pencil. So this is a requirement. So what I'm saying is here, in order to project the upper lip, we need to do some transcutaneous injection into the medial tubercle of the lip. And in order to push that lower lip inwards, think about the mechanism for this. If I inject the chin here, there's very little impact on the lip. But if I inject labiomental crease and I give a mechanical blockade to the natalis muscle, look what happens. I rotate the lip inwards. So this injection, therefore, becomes important. So what we've got here is quite a simple explanation of how do we take a young lip that has a structural issue and correct it by using an indirect technique. So the total face for her, for the lip, this is 1, 2, 3, 4. We'll do the tear trough as well because we've got plenty of time. So 1, 2, 3, 4, 5, 6, 7, 8, and also she needs a little pre-jar sulcus, 9, and the lateral labiomental crease, 10. So she's a 10 injection point patient, which means that her aesthetic score for today is 10 minus 1.0, because I subtract for every point I subtract 0.1. And so to take her from a 9 out of 10 into a 10 out of 10 is pretty straightforward. There's no real structural obstruction to not make me achieve that result. Okay, so let's begin.
Any question in the meantime about the assessment? This is Raj Aquila's, I would say, masterpiece all the time. A perfect assessment of face. Any remarks? Someone who would do this different? Raj, everybody agrees fully.
No. Yeah, please. So actually what we're going to do is, we'll imagine that we are in the clinic and you know, a patient, imagine she's on the budget, so she can't afford everything all at once. So let's work first of all with Juvederm Voluma. And I'm going to inject Voluma into the structural points, means temple, zygoma, pregal sulcus, chin. Then we're going to switch the product into Volift. Now imagine that patient has been sent away after the Voluma session and she comes back 1 month later because she's saving money for the next session. Then we use the Volift and we're going to inject the Volift into the areas where we have a little bit more dynamic change in the tissue. So, medial cheek, alar base, upper lip, and labiomental crease. And then the job is done. Thank you. Voluma first, please. Yeah, thank you. Perfect. Good. So, let's turn this way. The first and most effective injection point in the whole face is here, okay? The zygomatic arch. Because you can see by this gesture with my finger what happens. Look to the camera, please. So by doing this, you can see that there is a relationship through to the lateral canthus, to the tear trough, to the nasolabial fold, to the buccal fat excess, which all girls hate this little excessive fat, and also to the jawline and the pregal sulcus. So this point has a huge impact. The way to identify it very objectively, and we need to be accurate here, is you need to feel on the zygomatic arch, where is the notch? Where the notch is the position of a retaining ligament. And this retaining ligament, it connects the skin to the bone. So as she ages, this retaining ligament is going to fall forwards like this. So by injecting medial to the ligament as it falls, I'm going to push it back. So it's a very important anchor point for injection facelift. So I've put the dot on the face, I retract the tissue, and then I'm going to inject just medial to that point. So we're going to go straight down to the zygomatic arch, right here. You see, because she's female, the angle of my needle is slightly more tilted vertically because I want to create a nice high cheekbone structure. I make a really slow injection. Now what you see, you know, with aspiration, we talk about aspiration all the time. I aspirate most points, but you know this one is the one that I say we don't really need to aspirate. There's nothing here on the zygomatic arch. So nice and slow. You can see with my non-dominant hand, the index finger and the thumb is restricting the material to within the surface of the zygomatic arch. So my injection volume now is 0.2, and we'll stop there because we don't want to over-project her. You know, on the measurement of the lateral fifth, she's already projected here. So I make a molding now, take the product, and I'm going to push the voluma against the little retaining ligament, just like this. And in doing so, what I'm doing is I'm forcing the ligament to become more vertical, and I'm also able to define the zygomatic arch. I'll show you another little trick that I use, especially in female patients. Take your finger and just mold that voluma against the inferior border of the zygoma. So this generates a very high definition subzygomatic sulcus, and this is very, very beautiful. You know, you girls who do the contouring makeup, and I know in the Middle East you love to do this, this really beautifies the mid-face. Show them the camera now, and then see like this.
That is very obvious.
You You see, Kun,
Yeah.
when you do this, and especially with a patient like this, because she's quite beautiful, you know, but she's got this sad look. So look, when I turn her now,
She has one.
she has this wonderful silhouette below the cheekbone, and everything else gets lifted. Let's look at the AP. Look into the camera now. There's a few things that have already happened. Number one, the brow starts to come up. Number two, the eye starts to become more tilted upwards, and the eye starts to now look a little bit more happy. And then also, the corner of the mouth, can you see this? Already starting to tilt up towards her left ear. So then, when I start in the cheekbone, when I'm doing the lips, it explains why I'm doing it, but also, people think then you're crazy starting here to influence the lip, but this is the relationship that it has. And let me just explain the mechanism. Why does the brow go up? When I inject here, I stretch the fibers of orbicularis oculi. When I stretch those fibers of orbicularis oculi, I weaken it because it can't contract so much. As a result of this weakening, the frontalis fibers laterally become more dominant and we get a little brow lifting. The other thing is, the structural support of the zygomatic arch gives a vertical support here for the lateral campus. And then of course, zygomaticus major, which inserts here. When I'm projecting at the cheekbone, there is better support for that muscle, so there is a mechanical lifting in the corner of the mouth. Okay, we stay with the voluma now because we're still in our voluma session. Let's go back, thank you. We're going to help this brow along a little bit more as well, so we're going to do the temple now. So the landmarks for this are very important. You have the temporal fusion line right here. And the intersection of that temporal fusion line with the orbital crest is there. If I go up the line 1 centimeter here, then I go down into the fossa 1 centimeter, I go back to the orbital crest at 1 centimeter, you can see a square. Now this square is a relatively safe square because you've got 3 vessels here: superficial temporal artery, posterior deep temporal artery, anterior deep temporal artery. This one runs all the way, this one runs half the way, this one runs 1/3 of the way up. Therefore, this region is safe. Also, not to forget, if this is a swimming pool with the deep end and the shallow end, the muscle here at the origin is thick, the muscle here is thin. The muscle therefore takes a rich blood supply, and here it takes a weak blood supply. Means this is dangerous, this is safe. So most people will look at the temple and inject the area of the deepest concavity, and it's the most dangerous approach, especially if you don't touch the bone, because the arteries are running within the body of the muscle. If you go to the bone here, underneath the deep temporal fascia, the product will flow down through the fossa, and you'll have one uniform correction from one shot. Okay, so let's do that now. I'll have a little palpation just to make sure I've got no little frontal branch of the artery. And then we can go. It's actually corresponding to exactly where this little purple dot is. So we're going to go down all the way to the bone. Touch the periosteum. Do you know, one thing I've learned about doing live demos, Kun, is that when I use the B word, the patient doesn't like it. So I always should refer to this as periosteum, right?
Yeah.
Okay. Big aspiration, you see the bubble, and then now we're safe to inject. You must aspirate in areas that are risk for at least 3 seconds to allow the arterial blood to overcome the product in the needle and the hub so that you can actually see a positive aspirate. And for those of you that don't believe in aspiration, you should have been with us in Bahrain 2 days ago. We had 2 positives in 1 day. Nice and slow. And what I'm doing is I'm watching this material. Look, it's flowing underneath the deep temporal fascia here. And there's no bulging or bumping of the material because I'm in the right plane. If you were to inject within the muscle or maybe even into the superficial layers, you'll see irregularities as you're injecting. So once this is done, I come out. And just to bear in mind as well, with the female temple, have a think about this 1 second. Do you think that the female temple, guys, do you think it should be either concave, flat, or convex?
Let me do a poll here.
Okay.
Concave, flat, convex. Apparently nobody has a clue here.
They're all still waking up.
Yeah, yeah.
All right, but listen.
Why don't you explain this?
Yeah, think about the male patient, okay?